All right, so this PowerPoint presentation is in D2L, and I just want to describe some of the terms that you'll be coming across when you're looking for your different articles. Evidence-based medicine is when you're looking at an article that has been reviewed by specialists in the area of medicine. So if they approve that the research is legitimate, it's considered evidence-based medicine.
Under what tab is this PowerPoint?
So lives are precious. We want to be sure we are practicing medicine that is proven to be effective and safe. In critical care, your opinion has the most weight when it is backed by well-designed studies, unlikely to be influenced by bias or chance. Strong studies in which you have drawn your own conclusions about the data presented. We call this evidence-based medicine, and it is today's difference between a respiratory tech and a respiratory care practitioner. So just to say, you heard about a study and I think we should do this, it's better to show proof of what you're talking about. So it's better to have those articles ready when you're talking to the intensivist about what you want. So when you're searching in Wikipedia, it's not evidence-based medicine. It's just people write in that have information about a topic. So Wikipedia is definitely not the place to go to get evidence-based medicine. When you're looking in your respiratory care journal and other medical journals, those are backed by evidence, by peer-reviewed articles. Peer review is a process by which a scholarly work, such as a paper or a research proposal, is checked by a group of experts in the same field to make sure it meets the necessary standards before it is published or accepted. So the anatomy of a study. Let's walk through this. One of the descriptions of the paper, it's going to say a prospective study was done, or it's going to say a retrospective study was done. And it has to do with prospective being, it's going to happen in the future. So you're planning this study and it's going to happen. Retrospective is you're looking back at records to analyze what has already happened. So if we want to go through, go to medical records department at the hospital and look through medical records of patients that were on the ventilator, let's say we want to check plateau pressures. That would be considered a retrospective study because we're looking at past data. We're not setting up the study to do a study in the future. Another term you come across a lot is meta-analysis, and that's when statistics are combined from several different studies. So if there's 25 different studies on the best flows for high flow nasal cannula and what flows improved oxygenation, so they'll look at a whole bunch of studies and come up with a conclusion on all of that data. So that's a meta-analysis. So when you see the word meta, you know it's looking at several different studies and combining the statistics. An observational study is viewing what is happening without intervening. So this is typical of your infection control nurses watching everybody. So when you're in the ICU and somebody's standing around watching you to see if you're washing your hands before you go into the patient's room, that person isn't interfering with anything. They're just observing. So if they come up with data that 30% of healthcare workers wash their hands before entering the patient's room, that would be considered an observational study. Make sense? Interventional is when you manipulate variables in order to study them. So if a study is interventional, the study has to be approved by an institutional review board. So every hospital has this board of people that have to hear what research you want to do. So if we want to measure plateau pressures on everybody, we have to submit to the review board and ask for their permission. And if they say yes, then we also have to explain to, well, the patient won't be able to say anything, they're intubated, but we would have to ask the family's permission to do a plateau pressure for our study. So what makes a reliable study? Number one, the number of people in a study. So as you might expect, the higher the number, the better the strength of the study. So if the study is done on one person and you get results, how valuable is that? However, if you did the study on many people, then it's going to be more reliable statistics. The ARDS study was in 2003. Wow, that's a long time ago. And many hospitals throughout the country participated, and everybody was using 10 to 15 mLs per kilogram for tidal volume on patients. 10 to 15 ml, and they were not figuring out ideal body weight. So can you imagine how overventilated people were and why there were no beds at Kindred? Because so many lungs were damaged from these high tidal volumes. And so when they did the study, they compared the 10 to 15 ml per kilogram group with 4 to 6 ml kilogram group. The survival rate was much higher if they were using small tidal volumes. A lot of people were dying with the bigger tidal volumes. But the point was that they used a lot of different hospitals to come up with this information. So it ended up being a very reliable study. If it says a single center study was done, it's just one hospital. If it says multi-center, then many hospitals were involved in the study. A control group. A control group is a group that doesn't get the intervention. So if it's a pill, let's say we're trying out a new type of Advil, and we have a pill and we give it to the patient and we want to know what difference it made. You know, did the headache go away? Do they have any side effects? Well, we also give that pill, a fake pill, to another group of patients that it doesn't have any of the Advil type drug in it at all. We're just giving them the pill and asking them the same questions. So if everybody says, oh, you know, afterward, I got really tired and I went to sleep. Well, if it happened in the control group and it's happening in the group that actually got the pill, then falling asleep has nothing to do with the pill. Does that make sense? So that's why you have a control group and your experimental group. Oh, and then when you get that fake pill, it's called a placebo. So what have I got about this? So randomly putting a patient in a group is the best way to go about it, but it can't be biased. For example, if you're studying the effects of inhaled Pulmicort on premature infants, you can't say, oh, this one's a lot sicker, so we're going to use Pulmicort here and put them in our study group. And this group isn't as sick, so we're going to put them in our control group. So you can't pick and choose who's going to be in your study. Blinding. I like the picture of the blindfold on the person. The less people that are aware of whether the person is a control or in the experiment group, the greater the strength of the study, because there will be less bias. So if you don't know and the patient doesn't know, that's when we're going to get the most honest results. Because if you do know, oh, okay, this person's actually in the experiment group, I'm going to make sure that I fluff their pillow and smile. That group, I know that they're just getting a placebo, so I'm not even going to pay attention to them. No, so that's showing bias. So they have blinded experiments. Single blinded is when just the participant is unaware of the group that they are in. Double blinded, neither the participant nor the investigators are aware of which group they are in. And I remember this happening at Joe DiMaggio when nitric oxide was first coming out. They would give babies that had pulmonary hypertension were given this cylinder of a gas, and the gas was, or the cylinder was covered. So the therapist couldn't see who was getting what. So the therapist didn't know, as well as obviously the baby didn't know, but that would be double blinded. So the investigator and the participant not knowing, it's a double blinded study.
What was in the placebo?
I don't know. Yeah, good question. Was it just room air? Was it? Yeah. Good point. Yeah. And then there's a crossover study. So crossover means that you have a control group and then you have your experiment group, and you give them the pill or the gas to breathe in or whatever. Then after that, you cross over, and now the control group actually gets the pill or the gas or whatever, and the other group ends up being the control. So it's kind of switching just in case it makes a difference. So it says the same patient can be assigned to both the treatment and the control group. They're placed randomly in either control or experiment for a set period of time, but then they are crossed over to the other group. This is about the time when Tiffany starts yawning. Okay. So putting it all together, what is a randomized controlled double-blind crossover study? Can you pick it apart and tell me? So randomized. Right, very good. Very good. Good job. And then what about crossover? Yes. Between the control and the actual experiment. Very good. All right. Good job, Tiffany. You can go back to sleep. Anybody want to try a retrospective controlled observational study? So what does retrospective mean? Excellent. Good job. And you have a control group, I guess, somehow. All right. Good job. So randomized controlled trials are the primary means of testing the safety and efficacy of meds and therapies. It's usually interventional. So we're going to plan this study. Prospective, which means what? It hasn't happened yet. We're planning it for a future study. We're going to randomize everybody. We're not going to know who gets what, blinded. And we're matched to a control or experimental group. Okay, and now for the statistics. With statistics, have you guys had this course where you have to find your p-values and find your confidence intervals? Yeah, no? You did. You did. I have a mental block when it comes to calculating the values. So the only thing I do with you guys is I tell you the what's good and what's bad. So if you get a p-value, I tell you a good p-value, and that's about it, because I can't figure out how to calculate all this. So with p-values, it says probability values are calculated. They can be thought of as the probability that the statistics and results are in error. So p-value gives us the strength of the result. The result isn't as easy as a yes or no. So if you have a p-value of less than 0.05, the probability of making this error is less than 5%. So 95% of the time, there is no error. So a little p-value is good, meaning that the study has strong evidence. Let me see if I wrote anything else. If it's greater than 0.05, that tells us that the evidence is weak. Yeah, I asked my son is a research scientist at the cancer center in Tampa, Moffitt Cancer Center. So this is his bread and butter. So you think, okay, Yvonne's got a really good resource here to figure all this stuff out. I lose him like after the first minute. So he says, oh yeah, mom, that has to do with the null hypothesis, da, 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 da. I don't know what a null hypothesis is. So I never understood the explanation, but here, let me just put in the chat what I do understand. I don't know how these words are. So p-value less than 0.05 is good. It means there's a 95% reliable evidence. So highly supported evidence for whatever conclusion the study is coming to. Okay, and then greater than 0.05 is not good. So a p-value greater than 0.05 is not good. It means that the evidence is weak. So let's look for p-values in this highlighted area. So this is an abstract. It has a few paragraphs. I know I told you that usually an abstract is just one paragraph. This one has more than one. But in the results, from 183 patients who completed a pulmonary rehab program, 93 had COPD, 78 were male, 15 were females. The mean age had plus or minus standard deviations of 68.6 plus or plus or minus 9 years. After the pulmonary rehab program, there were fewer, although not statistically significantly different hospital admissions. So it says 2.1 versus 1.7, and the p-value is 0.17. Is 0.17 good? No. So it was not statistically significant that the pulmonary rehab kept the patients out of the hospital. Does that make sense? So they gathered statistics and realized, no, we're not showing evidence that it makes a difference. 3 years after the pulmonary rehab program, 34 subjects died, hypercapnic respiratory failure, p-value 0.02. That's not less than, right? That's okay. Non-invasive ventilation, 0.002, and then lung cancer 0.001, shorter 6-minute walk distance, that has a low p-value, a higher number of previous hospital admissions, a really low p-value. Those were associated with a higher mortality rate. So all those things were statistically significant in showing that these people are going to die pretty much within 3 years. So is that a good example of p-value? The next one you come across all the time, almost every paper has a confidence interval. It's looking to see if you can reproduce the data if you repeat the experiment. You want to see 95% or higher, meaning that, okay, if we decide we're going to do the experiment that we just read about, and we do everything exactly like they did in their experiment, we should come out with the same results. So if we do it 95 times, then we should all, or if we do it 100 times, at least 95 times doing it, it should be the same as what we're reading about. That would give us a confidence interval of 95% or higher. What are the chances that another sample of the same population will have the same results? How much can we trust the average? For example, if we take 100 people and say that 50% of them will have a red light outside of the school when turning left, what are the chances that a different 100 people will have that same 50% chance of a red light? So I don't know if the red light is on a timer or if it's always the same, but assuming that red light's always the same, what are the chances that, how many people will hit the red light? Then we repeat the study again, how many people hit the red light? And then we repeat it again, how many people hit the red light? If we keep getting the same statistics, then we would have a high confidence interval. And usually it has the margin of error, so plus or minus 10% associated with it, or this is an example of the margin of error. Okay. All right, so just a couple more things to tell you. Have you heard of sensitivity and specificity? No? With the COVID vaccine, if you are, if you do a PCR test and your test comes back negative, what are the chances that it's really negative? So if it's really accurate, we're looking at sensitivity. I didn't say it right, did I? So if your test came back positive, the sensitivity identifies the sick people who are really sick. So if you are really sick with COVID, your PCR test comes back positive, then there's a high sensitivity. And then specificity is your test comes back negative. It identifies people who are not sick correctly, as those are actually not sick. What? It identifies the people correctly as not being sick. So they're really truly negative. So truly positive, truly negative. If you're truly positive, it's referred to as sensitivity. Truly negative, it's specificity. Okay, you're going to come across different categories in your journal article. And again, I want you to have one full journal article. It's okay to have 4 abstracts, but I do want you to see a journal article. It'll have the title with the authors, their affiliations at whatever institution. The abstract will be a summary at the very beginning of the paper. Then you'll have an introduction where they give you background information and what their hypothesis is and what they're trying to prove. Then they'll go into methods, and that'll be the details of how they conducted the study. After the methods, then they'll show you the results, summary of results with supporting figures and tables. And at the end, they discuss what they came up with. So there's always a discussion at the end. And then, of course, references. Oh, I didn't tell you about that. So when you find one article, at the end of the article, they list all the other articles that they use to write their paper. And that's a good place to look to give you a clue to find some more articles. I forgot about that. So that's a good way to find stuff. All right, so here's an article, Decreasing the Adverse Effects of Endotracheal Suctioning During Mechanical Ventilation by Changing Practice. So all the authors are listed. And then in the background, it says little is known about the incidence of and risk factors for adverse effects from endotracheal suctioning. We studied the incidence and risk factors and evaluated the effect of suctioning practice guidelines. The methods during a 3-month period in 79 mechanically ventilated subjects. We recorded the adverse effects in 4,506 suctioning procedures. Oh, that's a lot of suctioning. 79 people got suctioned 4,000 times. Oh,
Yeah, that's true. With the pressure just on full. Yeah.
oh no.
With the vacuum just on full.
That's a lot of suctioning. The practice guidelines were implemented 1 year later during another 3-month period in 68 subjects. We recorded adverse effects in 4,900, so they still suction just as much. In the first period, adverse effects occurred frequently. O2 desaturation occurred in 6%, in half of the subjects and 6% of their suctioning. Hemorrhagic secretions, 31% of subjects, 4% of suctioning. Blood pressure change in 24% of subjects. Heart rate change in 10% of subjects. Wow. So they're saying complications decreased from 59% to 42%, giving you a p-value of less than 0.05. So we can believe that it's reliable information. PEEP greater than 5 was an independent risk factor. Greater than 6 suctionings per day was a risk factor for desaturation and hemorrhagic secretions. They had to do a study to figure that out. I think that was all I wanted to tell you. Did you know that you can Google Scholar, and that is also a really good database of medical journals? PubMed is your national government, and so is Medline. And then I want to tell you about Cochrane reviews. Sometimes, especially with kids, Cochrane reviews become the standard of care because you can't do experiments on children and babies. So instead of doing an experiment, they come to a conclusion just based on what they see clinically. And that's called a Cochrane review. And then it mentions some journal, which I told you about already. I think we talked about all this stuff already. So it says abstract, full text. So the abstract is the short paragraph and then the full text is everything. These are all just examples of what we talked about already. Okay, that's all I have to say. Thank you for coming to my TED Talk.
We really are, and we like it.
Oh, thank you for that.